Thank you for joining us, and good afternoon, or good evening, or good morning, depending on when and from where you're joining us. I'm Dr. Phoebe Thorpe, and it's my pleasure to welcome you to CDC's Public Health Grand Rounds for November 2016, Improving the Lives of People with Sickle Cell Disease. We have an exciting session, so let's get started, but first, a few housekeeping slides. We do have continuing education credits available for physicians, nurses, pharmacists, veterinarians, and health educators, and a couple other groups. Please see our Public Health Grand Rounds website for more information. This is our disclosure for this session. In addition to our website, we are also available on all your favorite social media sites, and we are live tweeting today, so please use hashtag CDC Grand Rounds for all your tweeting needs. We also feature a video segment, Beyond the Data, which is posted after the session. This month's segment features my interview with Dr. Hassel. We have also partnered with the CDC Public Health Library and Information Center to feature scientific articles related to sickle cell disease. Please see cdc.gov/science clips for more details. Here is a preview of the upcoming Public Health Grand Round sessions. In addition to today's speakers, I'd like to take a moment to thank the individuals listed here. Thank you. And now for a few words from CDC's director, Dr. Frieden.
Sickle cell is an inherited disorder that causes lifelong health challenges with the potential for sudden and devastating consequences. Sickle cell disease disproportionately affects minorities in the U.S., especially African American and Hispanic communities. In 1973, the average lifespan of a person with sickle cell disease in the U.S. was only 14 years. Today, the average lifespan is 42 years. These numbers demonstrate both how far we've come and how far we have to go. I've personally cared for many patients with sickle cell disease, and I appreciate how painful and difficult it can be. The progress we've made results from collaboration among many partners: clinical research, public health, patient advocacy groups, and the broader sickle cell community. Clinical research has advanced our understanding of treatments that prevent acute crises and strokes, which are the major causes of morbidity in sickle cell disease. Preventing pneumococcal disease through vaccination and newborn screening that identifies affected infants are some of the ways public health has contributed to reducing early mortality. We have much more to do to prevent sickle cell, either through counseling approaches or, in the future, new modalities. In the U.S., more than 90% of children with sickle cell live to adulthood, but there are still important gaps in care and areas for improvement, especially for teenagers and young adults with sickle cell disease. Figuring out how to close these gaps requires that we know what works and accurately evaluate how well it works. Past CDC efforts, some of which you'll hear about today, were among the first to develop population-based surveillance systems. Current CDC efforts, including the Sickle Cell Data Collection Program, build on these efforts by collecting information about healthcare and outcomes throughout the entire lifespan of people with sickle cell disease. This data will support basic and clinical science advances, healthcare system changes, and patient, provider, and health system-centered policy solutions. As you'll hear today, we've made progress treating sickle cell disease and the complications of it over the past 4 decades. Through continued collaboration, we can better understand the disease and its treatment and improve the quality of life and outcomes for people living with sickle cell disease.
And now for our first speaker, Dr. Mary Houlihan.
So good afternoon, everyone, and thank you for joining us to learn more about using data to understand gaps in care and outcomes for sickle cell disease. The term sickle cell disease, or SCD, describes a group of inherited red blood cell disorders. People with SCD have abnormal hemoglobin, called hemoglobin S, or sickle hemoglobin, in their red blood cells. Sickle hemoglobin, seen here on the left, can form stiff rods within the red cell, changing it into a crescent or a sickle shape. These red blood cells are not flexible and can stick to the vessel walls, causing a blockage that slows or stops blood flow. When this happens, oxygen can't reach nearby tissues. For comparison, on the right side are red blood cells with normal hemoglobin that are disc-shaped. In all forms of SCD, at least one of the two abnormal hemoglobin genes causes a person's body to make hemoglobin S. Hemoglobin SS, also called sickle cell anemia, is the most common form of sickle cell disease in the US and the most severe. Hemoglobin SC disease and hemoglobin S beta thalassemia are other common forms of sickle cell disease. People who inherit only a single copy of hemoglobin S have sickle cell trait. People with sickle cell trait usually do not have any of the symptoms of SCD, but they can pass the trait on to their children. Two parents with trait need to go through genetic counseling, including awareness of their trait status, which is important. Globally, there are approximately 300,000 annual births with sickle cell anemia. Almost 80% of these births occur in sub-Saharan Africa. Unlike the United States, where more than 95% of patients with sickle cell disease will live past the age of 18, the under 5 mortality rate for children born in low and middle-income countries may be as high as 90%. Improved access to public health infrastructures and specific medical interventions are necessary in order to lower global sickle cell disease mortality. A diagnosis of sickle cell disease is often associated with multiple comorbidities. The lack of tissue oxygen caused by sickle hemoglobin can cause attacks of sudden, severe pain, called pain crises, which are the clinical hallmarks of sickle cell disease. The red cell sickling and poor oxygen delivery can also cause organ damage. Over a lifetime, SCD can harm a person's brain, spleen, eyes, lungs, liver, and multiple other organs and organ systems. These chronic complications may lead to early mortality. Individuals with the most severe form of SCD have a lifespan that is 2 to 3 decades shorter than those without sickle cell. And while the US has made tremendous strides in improving outcomes for children, as you can see here, beginning in the mid-teen years, there is a striking discrepancy between mortality rates for patients with SCD, shown as light blue columns, compared to the general African American population, shown as dark blue columns, and the total US population, shown as green columns. This difference in death rates continues throughout most of adulthood. Universal newborn screening for sickle cell disease is required in all 50 states and the District of Columbia, and is one strategy that has improved outcomes for children. However, there are no long-term follow-up programs, registries, or data collection systems, so the exact number of people living with sickle cell disease in the US is unknown. It is estimated to affect approximately 100,000 Americans. The map shown here shows the estimated prevalence of sickle cell disease by state. As you can see, while Florida and New York have more than 7,000 sickle cell patients each, many states in the Northwest may have less than 500. Through an interagency agreement with the NIH's National Heart, Lung, and Blood Institute, and led by CDC's Division of Blood Disorders, a population-based monitoring system called the Registry and Surveillance System for Hemoglobinopathies Project, or RUSH, was initiated in 2010 in the 7 states seen here in red. This project helped design the framework for statewide surveillance of sickle cell disease by using existing data sources to identify patients with SCD, and then using these same data sources to understand the healthcare utilization patterns of this population. In 2012, the Public Health Research, Epidemiology, and Surveillance for Hemoglobinopathies Project, or FRESH, was launched to evaluate and validate the RUSH methods and to begin disseminating findings from this monitoring system to various stakeholders, including patients and families, healthcare providers, and local, state, and national policymakers. FRESH was conducted in 2 of the original RUSH states, California and Georgia, and it was also included a 3rd state, Mississippi, to assess the feasibility of expanding the surveillance work to additional states at a reduced cost. In 2015, we began working on the most recent iteration of state-based surveillance, the Sickle Cell Data Collection Program, or SCDC. Building on the knowledge gained during RUSH and FRESH, The program will collect, synthesize, and disseminate multi-source, population-based longitudinal data for individuals with SCD. There are 4 main objectives for SCDC. The first and most basic is that it will establish a health profile of the SCD population. It will also track changes in SCD outcomes over time, ensure credible, scientifically sound information to inform standards of care, and inform policy and healthcare practices. All of this together, we hope, will result in improved quality of life, life expectancy, and health among those living with SCD. Although we are currently working with only 2 states, we will be able to include about 10,000 patients with sickle cell disease, or about 10% of the US population in this project. To begin, SCDC will include surveillance data from 2004 through 2014, and additional years will be added as they become available. The system will include individual-level information from these data sources at a minimum: newborn screening, hospital discharge, Medicaid claims, emergency department, and death records. Additionally, there will be case reports from a number of clinical centers throughout the participating states. At this time, agreements for all of the source data are being finalized, and the master case file and infrastructure is under construction. Initial data analyses are beginning, and plans for dissemination of the results are being formulated. Our hope is to build upon these experiences and develop a training curriculum to educate additional states about the process for developing a population-based surveillance system for sickle cell disease. This training institute will establish goals and benchmarks for the participating states, and those successful in meeting these measures will be incorporated into the complete system. And so I would like to thank those of you who are direct participants in SCDC, the California Rare Disease Surveillance Program, and the Georgia Health Policy Center, as well as our partners who continue to support our efforts. As we develop and expand the SCDC program, we will continue to heavily rely upon the counsel, advice, and expertise of these groups, especially the patients with sickle cell disease and their families, who continue to educate us on the needs, challenges, and barriers that remain improving their health. Thank you so much for your attention, and I now would like to introduce Dr. Kim Smith-Whitley.
Good afternoon, and thank you for inviting me to participate in this CDC Public Health Grand Rounds. My discussion today will focus on advances and challenges in pediatric care in the sickle cell community. Sickle cell disease, as you have heard, is characterized by accelerated destruction of red cells, or hemolysis, vascular occlusion, and unpredictable clinical complications such as pain, life-threatening infection, stroke, and acute chest syndrome. Despite the fact that the first patient had been described in 1910 and the first diagnostic test was developed in 1949, by the late 1960s, sickle cell-related morbidity and mortality were still high. Based on concerns for equitable care, in 1971, the Sickle Cell Disease Association of America formed. This organization embodied multiple community-based organizations throughout the U.S. with the goal of improving the quality of life of those living with sickle cell and finding a cure. A year later, the National Sickle Cell Anemia Control Act passed. This legislation put in place resources to support sickle cell disease research and the infrastructure for clinical care. One of the first clinical research trials that came under the umbrella of support instituted by the Control Act addressed early childhood mortality, specifically pneumococcal sepsis. In a 1986 study that was halted early, oral penicillin was proven to prevent pneumococcal infections and sepsis in young children. The study recommended that prophylaxis start at 4 months of age. This led to the quandary of identifying infants early enough to benefit from this preventive treatment. The oral penicillin prophylaxis study largely provided the basis to advocate for newborn screening for sickle cell disease. Although the ability to diagnose sickle cell disease in newborns had been available since 1972, there was not evidence that detecting the disease earlier could alter the clinical outcomes. Although many states had already adopted newborn screening in 1987, it had not been widely adopted. Therefore, the NIH Consensus Conference recommended that all states adopt universal screening of newborns for sickle cell disease. Newborn screening, along with infection prevention programs that started penicillin in infancy and specialized vaccinations, reduced the mortality associated with pneumococcal infections. Another devastating complication of sickle cell disease in children is stroke. Historically, SCD was the most common cause of stroke in children. Infarctive strokes, where oxygen supply to the brain tissue is compromised, occurs in 15% of young children with sickle cell disease type SS. In children with sickle cell disease, these infarctive strokes are due to damaged, narrowed, or stenotic blood vessels. In 1992, using a non-invasive technique to estimate the flow of blood through the brain, researchers found that they could predict which children with sickle cell disease would develop stroke by using transcranial Doppler ultrasound. Since we knew that chronic transfusions or regular blood transfusions every 3 to 5 weeks could prevent recurrent strokes, researchers asked, was it possible that chronic transfusion therapy could prevent first strokes in children with sickle cell disease identified at high risk by TCD? 130 children participated in this randomized control trial. More strokes occurred on the observation arm than the transfusion arm, demonstrating a 92% reduction in stroke risk with chronic transfusion therapy. Another breakthrough has been hydroxyurea. Hydroxyurea is a chemotherapeutic agent that, when used at low doses, has a tolerable side effect profile and increases the production of fetal hemoglobin. A 1995 multi-center trial in adults with sickle cell disease asked the question whether hydroxyurea could decrease sickle cell disease-related complications. This study demonstrated fewer painful episodes, acute chest syndrome, and the need for transfusion therapy in the group randomized to hydroxyurea. Lastly, bone marrow transplantation is a cure for sickle cell disease. This 1996 study followed 22 patients with sickle cell disease who had a brother or sister without sickle cell who was an eligible bone marrow donor. This study demonstrated excellent results with 73% event-free survival. However, one of the great limitations is having an appropriate donor. In 20 years, only 1,000 transplants have been performed in this patient population. For children with sickle cell disease, great advances have been made to prevent complications before they occur or prevent complication recurrences. Recent research has advanced clinical care, but more is needed as disease-related morbidity and mortality remain high. There are no mechanisms in place to track the care provided to those with sickle cell disease. Moreover, there are few disease-modifying therapies or treatments to shorten the course of acute and chronic pain. Finally, there is no universal cure accessible to all with sickle cell disease. In addition, providing this improved care for children and adults with sickle cell disease has been challenging. We don't know where children and adults are living in the U.S., nor whether they are getting the health care that they need. Advocacy organizations such as the Sickle Cell Disease Association of America, or SCDAA, remain concerned about ways to best address these issues. In 2003, the Sickle Cell Disease Treatment Act supported increased health services for children and adults with sickle cell disease, but an update of this act is still waiting to be authorized in 2016. In 2014, in order to address these continued challenges in the sickle cell disease community, we adopted at SCDAA a new agenda to encourage one voice to support sickle cell disease through advocacy initiatives. increased access to high-quality health care across the lifespan, drug development, therapies, and programs to improve quality of life, and to also decrease disease-related complications, and then a cure accessible for all with sickle cell disease. As one way to begin to accomplish these goals, SCDAA developed Get Connected, an information-sharing, patient-powered registry. This is a database and network of multiple stakeholders in the sickle cell community: children and adults with sickle cell disease, their families, their communities, primarily community-based organizations, healthcare providers, government, and private industry stakeholders. This web-based platform is where all participants can receive information important to the sickle cell community. One focus has been to increase the number of patients with sickle cell disease who receive care in a medical home and increase awareness of hydroxyurea therapy. Through a HRSA grant, 35 community health workers were trained to find children and adults with sickle cell disease, connect them to a healthcare team, and enroll them in Get Connected to ensure follow-up and access to resources. In 15 states, in less than a year, 3,152 individuals have been enrolled, challenging one of the largest prospective cohorts only to have been raised through the cooperative study of sickle cell disease. In summary, we have made advances in pediatrics, but few have been made across the lifespan. A lack of data is impacting our ability to develop and steer future health policies. We hope Get Connected and the sickle cell data collection projects will help with this gap. Lastly, we need more access to healthcare professionals with expertise in sickle cell disease, not just for children, but also for adults with sickle cell. We have a relatively high rate of deaths in the young adult age group and decreased overall survival. We are all working towards healthier lives for children and adults with sickle cell disease. And the acknowledgements, I have to acknowledge the SCDAA Newborn Screening Program CBOs, because they truly keep the light shining. And with that, I thank you for your attention, and I'd now like to introduce Dr. Kathy Hassel.
I would like to add my thanks for the opportunity to participate in Grand Rounds today and to present my perspective as an academic hematologist who's worked for more than 20 years now with adults living with sickle cell disease. Using population surveillance to better understand the adult sickle cell disease, particularly premature death and the growing burden of chronic organ damage, may permit the identification of opportunities for prevention and intervention both in childhood and adulthood. It is also important to understand the impact of healthcare access and utilization on the course of the disease and on the successive implementations of interventions. Although the majority of children with all forms of sickle cell disease survive into adulthood, premature death has been recognized in consented cohorts, such as the cooperative study of sickle cell disease, in the Jamaican sickle cell population, and in a cohort of patients followed for more than 40 years at a single institution in Los Angeles. Death occurs earlier with the most severe form of the disease, hemoglobin SS, as compared to those with the milder hemoglobin SC disease and race-matched individuals without sickle cell disease. As depicted in the green bars on this graph, population surveillance data from the FRESH program that you heard outlined by Dr. Houlihan identifies more individuals than captured by other CDC mortality databases, as depicted in the blue bars. This demonstrates the potential, for example, to find survivors into later adulthood that appear to be missed by using other sources. Unfortunately, the average survival still appears to be around 42 years, similar to the cohort data that we just reviewed. Recognizing the distribution or shifts in the age at death potentially permits assessment of interventions on a population. As an example, the blue line on the graph demonstrates that in 1979, part of the population died in early childhood. Subsequent introduction of early childhood interventions, as described by Dr. Smith-Whitley, including newborn screening, prophylactic penicillin, and pneumococcal vaccinations, appeared to temporarily be associated with the disappearance of observed childhood deaths in 2006 and 2014. While important information is gleaned from whole population data, caution is warranted when interpreting results. The sickle cell data collection program does not yet distinguish between different types of sickle cell disease. As noted, there are significant differences in expected premature death between types of sickle cell disease, so determining an overall population average may overestimate the lifespan for those more severely affected and underestimate the lifespan for those with milder types of the disease. In addition, not all interventions are applied to all types of sickle cell disease. For example, hydroxyurea is of proven benefit, as you heard from Dr. Smith-Whitley, in sickle cell anemia or SS and S-beta-0 thalassemia. But 40% of individuals have other types of sickle cell disease and would not routinely be given this intervention. Assessment of the population as a whole without distinguishing type of disease may miss important gains within a given subset of the population. Another important aspect of adult sickle cell disease is the burden of chronic organ damage. A study of autopsies from more than 20 years ago revealed injury in targeted organs, including the lung, the kidneys, and the brain, with secondary injury in the liver and the heart, and noted that chronic organ damage was the second leading cause of death after infection. In a single institution cohort followed for more than 40 years of follow, 73% developed chronic organ damage. Although those earlier data suggested that infection was an important cause of death, more contemporary data indicate that chronic organ damage may now be the leading cause of death. A study of CDC death certificates suggested that cardiopulmonary and renal disease are common causes of death, and death due to infection is now less common. Only 20% of this cohort died during acute crisis. And comorbidities that affect individuals without sickle cell disease, like heart disease and hypertension and pneumonia, were also noted to be present. Discerning the presence of both sickle cell and potentially non-sickle cell related organ damage is important when planning prevention and intervention. Understanding the onset and progression of complications is also critical when planning strategies for prevention, early detection, and intervention. This slide depicts state Medicaid data from 5 states demonstrating an increase in the development of any complication, indicated by the red line, pain, indicated by the blue line, and the onset of pulmonary complications, indicated by the pink line, all of which appear to increase in mid-adolescence. Population surveillance can also characterize the use of interventions in an effort to understand impact. As an example, these Medicaid data suggest that there's a fall-off in the use of transfusion therapy beginning in mid-adolescence, seeming to correspond with that rise in complication and pain, although hydroxyurea use appears to remain stable into adulthood. Interesting data to stimulate both speculation and the need for further analysis. Another marker of increased disease activity may be the use of the emergency department, which may be necessary for acute complications and acute severe pain. Use of the ED has also been interpreted as an indicator of a lack of access to adequate routine health care. Note that this increase begins in mid-adolescence at around age 16. Thus, the planned sickle cell data collection program has the potential to clarify the course of the disease and factors that impact that course. Longitudinal tracking can identify the onset and progression of complications and determine the utilization and impact of both complication-specific and disease-modifying therapies. As previously noted, however, the inability to distinguish the type of sickle cell disease may confound interpretation of findings, as the rate and severity of the complications varies between different types of sickle cell disease, and disease-modifying therapies are not always applied to all patients. A final key area is access to and utilization of healthcare by adults living with sickle cell disease. The oft-stated assumption is that all children with sickle cell disease receive comprehensive sickle care from experts in sickle cell disease itself. Data from the Maryland Medicaid program suggests, however, that this may not be the case, indicating that 38% of children had not yet seen a hematologist by the age of 2. So it seems a careful examination of the pediatric landscape is warranted. Adult sickle cell care is most usually characterized as non-existent due to a lack of knowledgeable providers, or inaccessible due to a loss of insurance, or rendered by providers without any knowledge or interest. To date, I would submit that this is based on anecdotal experience rather than data. The increase in complications, ED utilization, and mortality in early adulthood is said to be evidence for the lack of adult health care. But the data we just reviewed suggested that these changes begin in mid-adolescence before transfer to an adult care provider has even been considered. With regard to the non-existence of adult sickle cell providers, this map depicts the number and location by state of adult hematologists or other physicians and advanced practice providers who indicate that they see adult sickle cell patients in the so-called Find a Hematologist service of the American Society of Hematology, or who participate in the Sickle Cell Adult Provider Network, which is an organization which promotes collaboration, research, and educational activities amongst adult providers. It should be noted that some of the most prominent members of the sickle cell provider community are not hematologists, but include internal medicine, primary care, and other types of providers who have developed considerable expertise in the management of sickle cell disease. So a surveillance system which captures sites of care and types of providers is likely to identify unrecognized cells of adult care as well as pediatric care. While most adults with sickle cell disease at any given time appear to have health care insurance of some type, most usually Medicaid and or Medicare, their plans may not cover necessary services or access to expert providers, and high deductibles might preclude utilization. There may also be intermittent loss of coverage when they lose a job that provided insurance, or ironically, when they gain a job that gives them too much income to make them eligible for some of these programs. An often overlooked aspect of the adult healthcare utilization is the role of self-determination. Adolescents, and especially newly autonomous young adults, may have access to knowledgeable providers, but elect to opt out of the healthcare system. As an example, this study demonstrated that 8 of 22 patients died within 5 years of a referral into an established adult sickle cell program. All 8 had declined to continue their disease-modifying chronic transfusion therapy. In this area, the opportunity of the Sickle Cell Data Collection Program is to understand where adolescents and young adults receive health care and observe the course of the disease while still in pediatric care, which in some programs extends into the early 20s. This may permit recognition of the changes in the biology of the disease and/or to understand the impact on the level of patient engagement. Unfortunately, the system will not be able to capture many efforts to provide care, including referrals, transfers, and scheduled appointments that were not kept, as data for services actually rendered are captured in the new system. Given this, the lack of utilization cannot be simply equated with a lack of access. Nonetheless, and despite these limitations, the Sickle Cell Data Collection Program will provide important population-level data about premature death, disease course, the impact of interventions, and healthcare utilization, and I believe identify providers and sites of care, informing the development of strategies for prevention and interventions that will help to lessen the burden of sickle cell disease. And now I'd like to introduce my colleague, Dr. Jean Raphael, to discuss implications for healthcare policies.
Great. Thank you for having me here. So again, my goal for today is to really discuss the policy implications of what's been discussed so far. So I'll do that through 3 objectives. So one, I'll talk about the current guiding principles in healthcare policy and healthcare policy initiatives. The second objective is to identify policy challenges currently occurring in sickle cell disease. And then lastly, I'll outline a policy agenda for sickle cell disease to improve care. So increasingly, health policymakers have advocated the triple aim as a model for improving population health. So the triple aim has 3 core aspects. So the first is reducing cost. And more specifically, that means eliminating overuse or misuse of diagnostic tests or therapies. It also means ensuring there aren't redundancies in care that occur with different patients, either with sickle cell disease or other chronic conditions. The second core principle of the triple aim is improving population health. And so there are 2 aspects to this. So the first is identifying systematic variations in care outcomes, being able to look across a population, take that data, and then to be able to apply that knowledge to develop policies for improvement. The third aspect of the triple aim is enhancing patient experience. I think you've all heard a lot about patient experience lately. And so there are 2 parts to that. Is that one, you want to actively survey patients about their experiences in the healthcare system, whether they be in the outpatient setting or the inpatient setting. And then you want to take that data and then translate into how you do system redesign. And as a fundamental part of system redesign, you're going to involve those same patients and families and able to make improvements. So those are the core aspects of the triple aim for population health. So with the triple aim as the goal, researchers and policymakers must articulate a path towards achieving these aims. And in doing so, what you have to do is a comprehensive approach where you go all the way from the basic biomedical sciences all the way to improving population health and establishing policy. So how does that work? So it starts off with testing what care works. So this could be clinical efficacy research. And then from there, you move on to the next step. And the next step is testing who benefits from promising care. So that can involve outcomes research, that can involve comparative effectiveness research, where you compare different evidence-based solutions or strategies or medications to see which one works better for populations. And then also health services research, where you look at sort of the how of healthcare and what that means for patients. And then the next step is testing how to deliver high-quality care reliably and in all settings. So what does that practically mean? That means is ensuring that all these solutions and strategies you've come up with at this point can actually work in real environments, in urban environments, in rural environments as well. So it's really seeing what practically works. And if you can achieve all of that, then you get to this outcome of improving population health and really having an impact on policy. So while there have been efforts to make sickle cell disease a bigger part of health policy initiatives, these efforts have been consistently undermined by insufficient data, as we've talked about before. So here's a great example. So look at Healthy People 2020. Hemoglobinopathies, of which sickle cell is one, were well represented in Healthy People 2020. So one, there was a focus on treatment, sort of screening for complications and disease-modifying therapies. And there was a second focus on access to a medical home, community resources, educational support. So this was a great opportunity to really affect the care of sickle cell disease. But what happened over time is they actually had to retire these objectives because there was insufficient data systems to actually assess them. So again, a great lost opportunity here where there was a great initiative, but then it could not succeed because we didn't have the necessary data to do it. So in order to assess what are the different types of policies that we can enact to improve care for sickle cell disease, we have to look at both the advances in sickle cell disease as well as some of the challenges. So here, outlining some of the advances, as we've talked about throughout these talks. So one is hydroxyurea as a disease-modifying therapy. The second is transcranial Doppler screening to assess stroke risk. Also, chronic disease transfusions to reduce stroke risk among individuals with sickle cell disease. And you take that all together with a number of other innovations, what you have is an extended life expectancy. So in 1973, where your typical individual with sickle cell disease would live to about 14 years of age, in 2008, life expectancy had exceeded 42 years of age. And you see those incremental improvements over time. So those are the advances in care. So now it's necessary to also talk about the challenges that remain. So one is just persistently high resource utilization. So we see that in the numbers of emergency care visits, hospitalizations, which contribute to significant and substantial medical expenditures. A second aspect is a high risk of mortality at early adulthood. So we see in that transition from pediatric care to adult care, you see an increase in morbidity and mortality as children make that transition. So that's another area of concern. The next thing, we just have a poorly studied population. A lot of that is due to poor funding and organizing that we see. So we have major advancements by the Sickle Cell Disease Association, as was outlined earlier, but overall, these are just efforts that could use more support over time. Other challenges also include, again, as we've talked about, lack of data sources with adequate numbers of people with sickle cell disease or a sufficient amount of clinical data to really make some appropriate changes in care. And then despite the fact of having new evidence-based guidelines come out in 2014, even with those guidelines, there are limitations in how much evidence we actually have for what we do with respect to sickle cell disease management. And then the last thing is Dr. Smith-Whitley had pointed out, there's just a limited number of clinical providers willing to take on this patient population, particularly in the adult world, particularly for people who are, for hematologists. So those are the challenges that we have. So as we outline an agenda for sickle cell disease, here are the things that I want you to consider today. First is population health and big data are essential. We've talked about through all our talks, it's so important to get the type of data where we can really look at what's going on systematically and then be able to make the policy changes to improve care. Another piece on the agenda is comparative effectiveness research of different treatments. So it could be clinical management, it could be medications, it could be approaches to care as well. And then the next thing, and this is going to sound counterintuitive, is really starting to look at technology-based interventions. So despite the fact that individuals with sickle cell disease tend to come from underserved populations, there is substantial data out there now that actually shows that these individuals have great access to technology. And this can mean cell phones, other mobile technology, text messaging, and in some cases, underserved populations have greater access than the majority population. Again, it's counterintuitive, but it allows you to know this is a place we can take advantage of because this is somewhere that people actually want interventions. So this could be health apps, it could be online programs. People have also done some work in terms of gaming, video games, avatars. So all of this has the potential to really meet patients where they are at their own convenience, where they don't have to go in for in-person interventions. They could do it all in which the way that makes sense to them. Another thing is just development of new funding strategies, whether it be looking at big data or whether it be looking at how technology can actually impact this population. Looking back at some of the clinical areas for priorities is building medical neighborhoods. So we hear about medical homes, but then there's this larger context of medical neighborhoods where primary care providers and specialists collaborate to take care of these patients. And from a policy perspective, what we want to do is decrease the barriers for these collaborations and really allow these people to meet together in a multidisciplinary fashion where people can really manage patients over time. Another aspect is supporting adult providers with expertise. So some of you may have heard of the ECHO program. So this is a model of care where you have these virtual learning networks of providers where providers in rural settings or underserved settings can really leverage the expertise of specialists. And this could be in sort of virtual case conferences where people from rural settings or underserved settings can present their patients, some of their clinical conundrums, and get, really great access to these experts who can help them manage these cases. So that's just a way just to increase the amount of resources available to these providers. Another thing we could do is modifying existing reimbursement models such that providers, specifically hematologists and primary care providers who are taking care of individuals with sickle cell disease, get reimbursed for care coordination because that is such a fundamental part of what needs to happen with this patient population. And the last thing is addressing the social determinants of health. So we've talked about this being an underserved population, a high number of these patients being on public insurance. So we can't just focus on what's going on in the healthcare sector. We actually have to go more proximal in terms of upstream factors to really address how to more effectively engage these patients in their care and to address some of the barriers they face in their daily lives. So what do we do now? So one thing is we've talked about all these phenomenal basic and clinical science innovations in sickle cell disease. So now we need the health policy strategies in place to really align what's been going on and really to make sure that the patients are able to reap the benefits of all these innovations. The second thing is these strategies really have to align with the current priorities in healthcare. So again, we talked about the triple aim, reducing healthcare costs, improving population health, and then enhancing patient experience. That's where people are really thinking about, and that's how providers are being incentivized. So our strategies really have to align with that model. The last thing is to make sure that these policy solutions are patient-centered, provider-centered, and lastly, health system-oriented. So as you've looked at all our talks for the last hour, I think there are a number of themes that have come out. So I just want to summarize them here before we start talking about specific questions. So one is that we need to continue the progress in advancing care. So again, I showed you that model of care, that roadmap, starting from the basic sciences going all the way to population health. We really need to more effectively translate all the great research into treatment and practice. The next thing is to use data to identify the gaps in care, and this is where population health and having access to big data is so important. So reducing the variability in disease course and management, the availability, use, and access to care, and then really focusing on that transition piece from pediatric to adult care, because that's where we're seeing this concern in terms of increased morbidity and mortality. And the last thing is we need more support to meet the healthcare needs of individuals with sickle cell disease. So connecting individuals to the right care, understanding which care is better for the individual. So although our main focus is on population health, we have to also balance that with personalized medicine as well. And the last thing is just overall developing better systems of care to provide patient-centered care. So with that, I think we'll go to the moderating and questions and answers.
Wonderful. Thank you so much for being here today. We are going to open up the question and answer session. And I didn't know if there were any questions from online or...
We do have questions from online, but I'd also like to take this opportunity to ask our online audiences, please do submit your questions and take advantage of the opportunity to get answers from this expert panel. From our Twitter audience, how useful is D-dimer test in distinguishing vaso-occlusive cause of pain from other causes in the patient with sickle cell disease?
So I'm certainly going to pass that to the clinicians in the room.
All right, so this is Kathy Hassel for our online audience. I happen to be a clotter most of my time when not doing sickle cell care in Colorado. So the D-dimer is an extraordinarily nonspecific test, and while elevations have been correlated roughly with course of disease, there are no biologic markers of whether or not an individual is experiencing a vaso-occlusive crisis. Remains a source of frustration for everyone that we can't simply draw a blood test and say, yes, you're in crisis, or no, you're not. It calls for believing the patient and what they're experiencing.
Great. Anybody want to add to that? Or wonderful. Thank you, Dr. Hassel. Any other questions from online?
Not yet, but we hope they're coming in soon.
Okay, great. Well, we can open it up to anybody here in the room today. There are microphones in the middle of the room in the aisle. If anybody has anything that they would like to ask, please do so.
I'll go ahead and ask the panel. I'm particularly interested in this troubling time between adolescence and adulthood, and this study which showed that some of these deaths were because the patients themselves decided to stop treatment. So I can imagine this being true for many chronic disease management issues. What do we know about how to help adolescents get ready for that transition mentally, emotionally, through the system, and try to get them into a place where we know what their barriers are going to be and we can help them make that transition?
So excellent question. And really, just to restate it just briefly, is really what do we know in the sickle cell community about this emerging adult population, between really 16 and 23 years of age? And the answer to that is really not much that is sickle cell specific. What we have done is adopted the American Academy of Pediatrics approach to really try to develop systematic process for transition from pediatric to adult-focused care. And now what we're trying to do is to see what best practices exist, I think, throughout the U.S., so that we can gather more information. And also, there is a recent grant funding through Patient-Centered Outcomes Research Institute that is going to look as a comparative effectiveness analysis at the different types of transition projects. And I think that we'll get a lot of meaningful information through that project. But I think that we need more data on what individuals actually experience in transition, not only from a personal level, but a health systems level and a healthcare provider level, which I think Dr. Hassel nicely framed. We need information from those stakeholders involved in the process before we understand what we need to do to make a tailored, systematic approach to sickle cell transition.
Okay, so I'll add the adult provider perspective. I think from my perspective, an important first step is to separate transfer and transition. 20-year-olds don't go to the children's hospital any more or less than they go to the adult hospital if they've been, selected to grow up and leave the children's hospital. Transition is a phase of life, not a site of care. And I think until we understand what it takes to care for a 20-year-old, whether they're still at the Balloon Boy Hospital or across the street at the grown-up hospital, there are needs that 18, 20, 22-year-olds have. Having two blessedly well sons myself, I know about this. They are invincible. They don't want to be told. And they not maliciously opt out. There are more important things to do. And if we continue to bury our efforts in the transfer to the adult provider who said no after the fourth no-show, we'll not get to the core issue of what young people need to assume responsibility for their health care, insofar as they're required to do so by law, by age of majority. I think, so it was a long way of saying I think we have to separate transfer from transition and figure out what a 20-year-old needs no matter who's taking care of them. And as I alluded to, I think the opportunity of the data collection that we have here is I can assert that I know the no-show rate isn't so good in Colorado at the Children's Hospital for a 20-year-old, but it'd be nice to see what the data show, because I have a bias about that, clearly strongly willed in that regard. But maybe the data will show something different, but we need to understand where care is being rendered and to what extent it's being engaged, sort of regardless of the site of care, as one of the key pieces in addressing this population's need.
And I was going to add also just about, again, about this need for research. And so I think in terms of sickle cell disease, there's been a ton of qualitative research done out there about, families having difficulty separating from the pediatric environment, the pediatrician or the pediatric hematologist having difficulty separating from the family. And so you have all those barriers there, but it's just what's been lacking is that quantitative data. And again, when you think about it, sickle cell disease being a fairly rare condition, so at each individual site, it's hard to get those numbers to really look at what works effectively in terms of a transition or transfer program. And so there are different programs going on at different individual institutions. But again, these are numbers with 30 patients, 50 patients. It's really difficult to put that together and say, okay, this is now an evidence-based strategy moving forward. And as Dr. Smith-Whitley pointed out, that's why the PCORI grant that is out there will be so important in terms of really being able to pool different centers together, pooling their data to say, okay, now in large numbers we can say what effectively works for transition.
Thank you so much. So I'll turn back to any online questions.
The writer wants to know if the clinicians use extended phenotype-matched blood for patients requiring chronic transfusion therapy.
So that's a very interesting question, and I think that one of the things that we've spoken about today are data gaps, and really trying to inform health policy on what evidence is there when there's very limited evidence. We have data to suggest that extended antigen-matched blood may lead to the lower development of red cell antibodies, finding appropriate red cell units that match that individual complicated, and also possibly placing that individual at risk for delayed hemolytic transfusion reactions. But just as we found that data, we have found other data to suggest just the opposite. So what we really need is a organized approach to a deeper dive in understanding the situation in which the individual receives the transfusion, because that might have something to do with development of these antibodies if the individual is in a healthy state as opposed to a sick state, where that donor blood is coming from, what are some of the characteristics of the individual, and then dive into more the basic science information about genotype, phenotype of the blood, and getting a large cohort together to work this out nationwide is one of the challenges that we face.
So you had the misfortune on this panel of having myself coming from the University of Colorado, where for more than 30 years, we are the only place in the world that does extended phenotype for 17 plus minor antigens. And so for us, alloimmunization does occur, the D-mosaic, these variations of Rh that we see, the occasional anti-U antibody, which even as a hematologist I had learned about before this. So I think I'm convinced it's great, it's wonderful in a population with few African Americans and yet 30 people receiving chronic exchange transfusion with 100 units a month. We can in fact sustain that in little old Colorado, but I completely agree with Dr. Smith-Whitley. if we could understand who is going to form alloantibodies, we could apply that in a more targeted fashion. We can do it only because it was long established for 30 years, and our regional blood center has that work, the setup, the very expensive part of that program done for a long time. So I do think much work needs to be done to understand how to target the very intensive matching strategies and who will be less likely to form those antibodies. And from an adult provider perspective, it's not just delayed transfusion reactions, but hemolytic disease of the newborn is a reality. And that is something that on top of everything else, we hate to pile on a young woman with sickle cell disease who has 3 alloantibodies, 2 of which could cross the placenta and hurt her baby. So it's not, it has impacts certainly beyond and in the adult world that we face.
And I just want to briefly add to, just to make sure that, everybody then can also know that there are evidence-based guidelines, that the expert panel report through NHLBI is out there, and many of us have contributed to that body of work, and we really do believe in antigen matching. The questions just become about how much, when, and how.
And then I'll just throw in from CDC's perspective, we do have, separate from what we spoke about today, but a project that we fund looking specifically at transfusion complications for hemoglobinopathies and ways to reduce those complications. So that is work that's going on that to some extent is very much addressing the questions and the points that were brought up here today. One more question from online.
From Twitter. Since people with sickle cell disease make people with sickle cell trait, where does sickle cell trait fit into the surveillance agenda?
So I would say that we recognize the importance of sickle cell trait from the issues of family planning, issues of reproductive counseling, genetic counseling. I will say that at this time, our resources at CDC are very limited, and so we are focusing our surveillance efforts on sickle cell disease. That is not to say that we do not have many ideas and projects sitting in the pipeline waiting to put into action as soon as we are able to. So it's a great question. It's something that's very important, and an individual's knowledge of their own personal sickle cell trait status is something that we certainly recommend, and something that we hope is in practice.
And then I'd just like to add that the Get Connected information sharing patient-powered registry will also incorporate sickle cell trait. So we're hoping that when the funding is in place for a research project to get underway, that will be an easily tappable resource.
So we have one question from the audience.
Dr. If you would you maybe talk about how the young lady presented at the National, you remember when she spoke about? So if you would say something about that, because I don't think that's known a lot, how that she was very upset.
One of the things that I think has been miscommunicated throughout the community is the experience of the individual living with sickle cell trait. And many individuals living with sickle cell trait may have been told at some point that this was an asymptomatic condition. And we do know that there are some symptoms that individuals with sickle cell trait experience. One of the things that has been brought to light is, blood in the urine or hematuria that can occur in individuals living with sickle cell trait and actually lead to some significant outcomes if not addressed. And then embedded in that is individuals who present with blood in their urine that then go on to have renal medullary carcinoma. And we don't really understand the relationship fully of sickle cell trait in the context of renal medullary carcinoma, but we know it's something that we have to be attentive to and look for, particularly in those individuals with hematuria. Many of us believe that there are other things going on in other genes that then have an effect and maybe have a more significant effect and role in those with sickle cell trait. But I think you bring up a very important point in that we really need to look at individuals living with sickle cell trait and their experiences and really get good data through research projects about the complications that they experience.
Can I just add one other comment? So in Denver, gosh, it's been probably a decade ago now, we had a young man in his teenage years succumb to renal medullary carcinoma. And I think his parents understandably were upset and concerned and actually, advocated that anyone living with sickle trait should have annual ultrasounds from the age of 2, and they're hoping to catch it early. And we need to learn more about why it occurs. It's such a rare thing. But the other point I wanted to make in terms of the broader picture is they were Caucasian and discounted by many of the sickle cell community because it must not be right, it can't be true. And I think there are many different persons of different colors, and including Caucasian individuals who may be affected by trait or disease. And while there's an appropriate focus, I think, on the predominantly affected community, it was illustrative, right, to see this young man succumb to a rare complication of trait when he was disbelieved that he could even have had that scenario. So it was just really eye-opening on many levels, I think.
That's all we have time for. Thank you so much for joining me, and please thank our speakers for an excellent presentation. And also, if you have a few minutes, stop on the down one floor at the library. They have put together an excellent sickle cell anemia display. Thank you again for joining us, and see you next month.